Hyperkinetic syndromes. Sami Badani. Parkinson and other movement disorders clinic. Neurology department. Carmel Medical Center Haifa. Dreamer. Definition. Oscillatory, usually rhythmical and regular movements affecting one or more body parts. Usually caused by alternating contraction of agonist and antagonist muscles. Classification by state of activity. Rest tremor is present when a limb is fully supported against gravity and the relevant muscles are not voluntarily activated. Action tremor, occurring during any voluntary muscle contraction which includes postural, kinetic, isometric and task-specific tremors. Postural tremor is apparent during the voluntary maintenance of a particular posture, which is opposed by the force of gravity. Kinetic tremor is evident during any type of movement. Intentional terminal tremor is the pronounced exacerbation of kinetic tremor towards the end of a goal-directed movement. Task-specific tremor only occurs during the performance of a highly skilled activity. Isometric tremor occurs when a voluntary muscle contraction is opposed by a rigid stationary object. Orthostatic tremor, a 14 to 16 Hz tremor that appears a few seconds after standing and subside on sitting or walking. Classification by etiology. Physiological and enhanced physiological. Present ataxion is more pronounced during periods of fatigue, fear or excitement. Results from numerous factors including the heart beat, low-pass filtering properties of striated muscles, motor neurons firing and synchronization by spindle feedback. Parkinsonian tremor. Slow 3 to 5 Hz rest tremor, pill rolling, involving the limbs and/or tongue, chin and lips. May be asymmetrical. May be accompanied by postural, reemergent tremor. Dystonic tremor. A jerky irregular action tremor intermingled with sustained muscular spasms that can last several seconds. May involve the muscles of the neck, tremulous spasmodic torticollis, face, orofacial dyskinesia, trunk and limbs. Midbrain, rubral, cerebellar outflow, tremor. A tremor which is present at rest, worse on posture and is further exacerbated by movement. This type of tremor is most commonly seen in MS and brainstem vascular lesions. Cerebellar tremor. A kinetic tremor with marked intentional component. The tremor is usually accompanied by disorders of ocular motility, dysmetria, nystagmus, incoordination, DDK pendular reflexes and unsteady gait. Essential tremor. Essential tremor, ET, is the most common movement disorder. It is a syndrome characterized by a slowly progressive, rapid, 4 to 12 Hz, postural and/or kinetic tremor, usually affecting both upper extremities. Epidemiology. The estimated prevalence of ET is 0.35.6% of the general population. Both sexes are affected equally, although head tremor may be more frequent in women. The prevalence of ET increases with age. Age of onset has bimodal peaks, one in late adolescence to early adulthood and a second in older adulthood. The mean age at presentation is 35 to 45 years. No association has been found between age of onset and severity or disability. ET disability. 85% of individuals with ET report significant changes in their livelihood and socializing. 15% report being seriously disabled by ET. Decreased quality of life results from both loss of function and embarrassment. In a study of hereditary ET, 25% changed jobs or took early retirement, 65% did not dine out, 30% did not attend parties, shop alone, partake of a favorite hobby or sport, or use public transportation, and 20% stopped driving. An estimated 0.5 to 11.1% of affected individuals seek medical attention. ET genetics. ET is familial in at least 50 to 70% of cases. Transmission is autosomal dominant, with incomplete penetrance. Some cases are sporadic with unknown etiology. 2 susceptibility loci have been found. The FET1 gene is located at 3q13 and was identified in 75 members of 16 Icelandic families. ETM2 gene at 2p2522 was identified in 15 members of 4 generations of Americans. ET pathophysiology. 2 neural circuits have been proposed to explain the pathophysiology of tremor. A basal ganglia thalamocortical motor loop involving the globus pallidum, anterior VL thalamic nucleus, and supplementary motor area may be affected in extrapyramidal tremor diseases such as PD and DT. Another loop, involving the cerebellum, posterior VL thalamic nucleus, and motor cortex, may explain tremor of other etiologies, e.g., cerebellar tremor. Treatment: propranolol primidone clozapine gabapentin benzodiazepines. Topamax. BTXA. Definition: dystonia is a movement disorder characterized by sustained muscle contractions that frequently cause twisting or repetitive movements in abnormal, sometimes painful, postures or positions. Classification, etiology, distribution of body regions affected. Primary. Secondary. Distribution of body regions affected. Age of onset, etiology, primary secondary dystonia the single sign. History, clinical and laboratory findings are normal. Usually action dystonia. Secondary. Associated with hereditary neurological diseases. Environmental, birth trauma or drug use. Psychogenic dystonia. Distribution of body, focal blepharospasm, cervical, laryngeal, hand. Segmental. MAGE, OMD. Multifocal. Different types. Hemidystonia. Vascular or CP. Generalized. Torsion dystonia. Dopa-responsive dystonia. Age of onset. Pathophysiology is not known. Reduced inhibition at various levels of motor system. Sensory motor disintegration of BG and motor cortex. Alteration of discharge rate and GPI. Treatment: levodopa and dopamine agonists, anticholinergics, clonazepam. Baclofen. Atypical neuroleptics. Tetrabenazine. Botulinum toxin type A, Botox, Dysport. Botulinum toxin type A, BTXA. BTXA acts as presynaptically at nerve terminals to prevent release of acetylcholine. Chemical denervation. Dimension coefficient 1916s 12/7. Molecular weight, kilodaltons, 900 500 300 150. Hemagglutinin. Non-toxic protein. Neurotoxin. LLLMS. Toxin type A B C 1 D E F G. Complexes LL, L, M, SL, M, SL, M, SL, M, SM, SM, S7. Sites of action of BTXA. Alpha motor neuron. Neuromuscular junction. Gamma motor neurons. Muscle spindles. Autonomic nervous system. Cholinergic nerve endings. C and A delta fibers. Central nervous system. Clinical applications of BTXA. Focal dystonias. Blepharospasm, lidopraxia. Oromandibular facial lingual dystonia. Cervical dystonia, torticollis. laryngeal dystonia, spasmodic dysphonia, task-specific dystonia, occupational cramps. Other focal dystonias, idiopathic, secondary. Other involuntary movements. Voice, head and limb tremor. Palatal myoclonus. Hemifacial spasm. Tics. Other applications. Protective ptosis. Essential hyperhidrosis. Cosmetic, wrinkles, facial asymmetry. Other inappropriate contractions. Strabismus. Nystagmus. Myokemia. Bruxism, TMJ. Stuttering. Painful rigidity. Muscle contraction headaches. Lumbosacral strain and back spasms. Radiculopathy with secondary muscle spasms. Spasticity, CP included. Spastic bladder. Achalasia, esophageal. Pelvirectal spasms, anismus, vaginismus. BTXA side effects overweakness, local pain, blue spots. Distant effects, rare. Loss of efficacy. Choreothetosis. Chorea, dance, irregular, rapid, uncontrolled, involuntary, excessive dyskinetic movements. Athetosis, not fixed, slow, sinuous writhing movements especially in the hands. Balismus, a form of chorea with large amplitude of the affected extremity. Choethetosis seems to result from damage of indirect pathways of the BG. These indirect pathways normally inhibit the unwanted movements. Etiology: vascular immune-mediated CP, metabolic, hereditary. Sydenham's chorea. CP. Metabolic. Hereditary. Huntington disease. Wilson disease, Huntington disease, age 35 to 50 years, rare, 4 to 10 105. Autosomal dominant chromosome 4, mutation of IT15 gene, repeats of amino acids, CAG, abnormal Huntington, genetic anticipation, paternal. Degenerative changes in caudate nucleus and putamen, spiny neurons and GABA. Mitochondrial dysfunction, excessive activation and excitotoxicity of glutamate apoptosis. Clinical manifestations. Behavioral, emotional and psychiatric disturbances. Cognitive decline. Motor disturbances. Chorea. Postural instability. Difficulty swallowing. Dysarthria. Motor impersistence. Treatment. Neuroleptics. BD. TBZ. Riluzole. Coenzyme Q10. Wilson disease, autosomal recessive, frequency 1/105, age 10 to 20 years. ATP7B gene, chromosome 13. Defect in transport of copper ceruloplasmin. Clinical manifestations. Non-neurological. Kaiser-Fleischer ring. Cirrhosis. Neurological. Tremor, chorea, dysphagia, dysarthria, Parkinsonism, hyperreflexia. Psychiatric. From agitation to schizophrenia, laboratory investigation. Low ceruloplasmin and copper in serum. Urine copper is high. Liver enzymes and liver biopsy. Normal CT or MRI of brain. Treatment: D-penicillamine, carpiridoxine. Trientine or tetrathiomoliptate. Zinc. Diet: cocoa, chocolate, liver, mushroom, nuts, shellfish. Tics and Tourette. Tics are involuntary movements or sounds. Motor and vocal, simple or complex. Non-rhythmic and repetitious. Sporadic and sudden. Simple motor, fast, brief, involve one or some muscles. Complex motor, sequent and simultaneous movements, produces purposeful movements. Simple vocal, solitary, meaningless sounds and noise, as sniffing, throat clearing, humming or coughing. Complex vocal, meaningful utterances and verbalizations as partial or complete words and repeated, coprolalia, echolalia and palalalia. Spectrum of tic disorders. Transient tic disorder. Childhood and adolescence. 4 times boys more than girls. Motor and or vocal tics. Maximum 1 year. Chronic single or multiple tic disorder. Motor or vocal, not both. More than 1 year. Tourette's syndrome, TS. Genetic, childhood onset, 1 to 20 years. Motor and vocal tics. Accompanied with ADHD, 80%, OCD, poor impulse control, anxiety, mood disorders and behavior disturbances, 20%. Males greater than female, 4 to 1. Affect 0.10.3 of general population. No definitive diagnostic test. Etiology of TS treatment is not known, 80% is genetic. Synaptic neurotransmission. Disinhibition of striatal thalamic cortical circuitry. Environmental factors. PANDAS. Treatment. Neuroleptic agents, antagonists and depleters. Antidepressants. Anti-anxiety. BTX, myoclonus definition, anatomic. Sudden, brief, shock-like movements which can be positive or negative, asterixis or flapping tremor. Anatomic. Cortical. Subcortical. Spinal. Peripheral, HFS. Etiologic, physiologic essential progressive myoclonic epilepsy. Secondary drugs, nocturnal, psychogenic, myoclonus dystonia, neurodegenerative, trauma, opsoclonus, myoclonus. Treatment. Antiepileptics. Benzodiazepines. BTXA, tardive dyskinesia, TD. Sigwald, 1959, first described TD. Involuntary movements typically of orobucolingual muscles, but any muscle in the body can be involved related to antipsychotic drugs. Mean prevalence 25%. Annual incidence rate 5% in young and 12% in elderly. Mechanism. Hypersensitivity and excessive function of dopaminergic neurotransmitters in BG. Higher risk young, female, affective disorders, poor treatment response to neuroleptics, dose duration and type of drug, holidays or interruption or increased dose, masked ED, anticholinergics, lithium, Parkinsonism. Treatment of TD, VT valproic acid, clonazepam, propranolol. CA channel blockers. Dopamine agonists. Atypical neuroleptics. Dopamine depleted tetrabenazine. Tetrabenazine, xenazine, nitumen. Has 2 modes of action. 1 blocking postsynaptic dopamine receptors. 2 depleting dopamine stores in presynaptic vesicles. Reduced transmission along dopamine pathways. Depleting stores of biogenic amines. For example, serotonin, noradrenaline, as well as dopamine. Binds to vesicular monoamine transporter 2, VMAT2. VMAT2 found primarily in the SNES. Vesicular monoamine transporter 2, VMAT2. Presynaptic vesicle. Dopamine. 2H+. VMAT2. Most common side effects. Drowsiness/fatigue. Parkinsonism. Depression. Nervousness/anxiety. Akathisia. Nausea/vomiting.